Any health-related information on the following show provides general information only. Content presented on any show by any host or guest should not be substituted for a doctor's advice. Always consult your physician before beginning any new diet, exercise, or treatment program.
Friends, welcome back to the Namaste Wellness Show, where we talk about all things holistic health for the mind, body, and spirit, for people and pets, with a touch of cultural soul. My name is Laura. Thank you for joining me again today. Today, I'm welcoming back one of my cousins, actually, Dr. Hazel Green Young. She is a radiologist at the University Hospital of Cleveland in the radiology department. And she also has 2 scholarships with Michigan State University and the Meharry Medical College. So welcome back, Dr. I was going to call you Dr. Hazel, but Dr. Young.
That's all right. I get, my maiden name was Green, and so a lot of people still call me Dr. Green.
Dr. Green, right.
Yes, thanks for having me back.
Well, I'm really glad that we finally were able to get back together. So today we're going to be talking about Dr. Young's work that she's been doing, research that she's been doing with sickle cell anemia, and just go ahead and tell us, update us on what's been going on in that with your research.
Okay. Well, first of all, I'd like to say that the opinions expressed are my own. I'm not speaking for any institution. But anyway, yes. A lot has been going on. As you mentioned, or as you were probably going to mention, I have received an award from the medical school here in Ohio.
Yes.
Physician Advisor of the Year. So I'm very proud of that.
Oh.
And also, I was contacted by one of the sickle cell nonprofits here in Cleveland that I have been working with. And they said that I will be getting an award from them in June.
Nice. Well, congratulations.
So the nice thing about this, I'm thrilled about both of them, but the nice thing about the second one is that it gives me, it acknowledges that I have been working with the sickle cell community to move the needle to help with this disease.
Okay.
So that's one of the nice things about that, because as a radiologist, I've had to reassure people that I knew something about what I was talking about.
Okay.
Radiologists as a specialty, though, we're already in a unique position because by virtue of what we do, we tend to know about a lot of different things. We know about OB, we know about pediatrics, we know about infectious disease, we know about surgery, and sickle cell. We see patients, x-rays who have suffer with sickle cell disease.
Well, let me ask you, did you get interested in the research because during radiology you were looking at x-rays or something of people that had sickle cell, or just tell us, how did you become interested in doing this research?
I'm not sure I understand entirely. I think there are a couple things. One is I'm African American, and it does affect a lot of African Americans. I'm also a very inquisitive person. There are few things in life that I don't have some interest in. I like to say I'm interested in everything but football.
Okay.
So,
and I just became interested in football in the last couple of years because the Lions have been winning. Okay.
So, but one thing that happened when I was a resident, one of my colleagues showed me an x-ray of a little child and the hand was swollen. And you could see the swelling on the x-ray. And they didn't know what it was. I said, well, is the child Black? And they said, yeah. I said, well, he probably has sickle dactylitis. So one of the first things that can happen when the children start to progress into having the disease, the sickle cell hemoglobin, is that they can get swelling and infarctions or damage to the bones of their hands, and it's called sickle dactylitis.
Oh, okay.
So even then, I sort of had it, because of maybe my personality and my race, I already was more in tune to some of this, the findings than my colleagues, for example. And then years later, when I was an attending, I got a call to look at a CAT scan on a patient because there was something very bright on the CT scan in the abdomen, and the physician didn't know what it was. They thought, well, maybe is it blood or what is this that I'm seeing? So I went and looked at the CT scan. Well, what it was a calcified spleen. And when you have sickle cell, every organ can potentially be damaged. And one of the ones that gets damaged is the spleen. So what the person was seeing but didn't recognize it was a small calcified spleen.
Now, when you say calcified spleen, what does that mean?
Okay, so the spleen is an organ in your abdomen that is responsible in part for your, providing immunities to keep you healthy from infections. So when you have sickle cell, like as an infant, and your spleen gets damaged, then you are at risk for dying of an infection or sepsis. So one of the first things they do to treat babies, infants, as soon as they're diagnosed with sickle cell, is put them on what we call prophylactic antibiotics. So since your spleen is not protecting you, then the physicians have to treat the patient to keep them from dying from an infection.
Wow. Okay.
So the spleen is just one of the organs in the body of patients with sickle cell that gets damaged.
But when you said the word calcified, is that like, what is that?
Well, that's just another way of saying that it is not functioning, that is diseased, and it's probably hard. Calcium tends to be hard.
Okay, that's what.
So it's like if you have stones in your gallbladder, stones in your kidney, those are calcified.
I see.
So it's sort of like the spleen can be calcified.
Okay. But the bottom line is that it seems like sickle cell anemia can cause different diseases. So it's not anything specific that a person could develop if they have sickle cell anemia. So anything could.
Well, any of the organs in the body can become diseased or abnormal.
Okay.
So the main thing, the main pathology of sickle cell is that organs in your body, parts of your body, are not going to get oxygen. So they're basically going to die.
Oh, wow. Okay.
So that means if you're not getting oxygen to your brain, you can have a stroke. If you're not getting oxygenation or oxygen to your heart, you can have a heart attack. If you don't get oxygen to your spleen or blood flow to your spleen, then it can atrophy, get small, and not function.
So that's why I guess the definition of sickle cell is that the blood is not providing the oxygen.
Correct.
And because the shape of the blood is sickle.
Right. So the shape does not allow for oxygen to be transported efficiently.
Okay. Okay, so that is, I didn't know, you're giving a good definition. I never really knew the definition of sickle cell, other than I know the blood cells were sickle shaped, but it didn't translate to me that because of that, it's not getting oxygen properly to the different organs of the body, and that's why the organs break down.
Right. So to go back even further, so the reason people have sickle cell and the numbers that we have is it's a mutation. It just spontaneously happened originally. And then people pass it on to their children, and their grandchildren can get it. So what happened is in places that have malaria, most of which are warm climates like in Africa, India, Southern Europe, the same feature that damages you makes it difficult. Those same sickle-shaped cells that don't transport oxygen are also good at preventing malaria from reproducing. So since it's not providing the nutrients or the oxygen or whatever you need to protect your body, it also prevents the malaria parasite from reproducing and causing damage in your body. So what happens?
The sickle cell prevents the malaria?
The shapes of the sickle cell, the deformity of the sickle cell, the decrease in oxygen is not hospitable is hostile to malaria parasites. It's kind of a crazy thing.
Yeah, because it's a good thing to prevent malaria, but yet it doesn't support the health of the organs.
However, nature does weird things. So it happens that if you just have the trait, you're less likely to die from malaria
Oh, okay.
because it's not hospitable to the malaria parasite.
Okay.
So if you have the trait, you're more likely to survive malaria than people who don't have the disease and who do have the disease and who don't have the trait. So that's why so many people in this country have the trait, because they stay alive longer than other people, long enough to reproduce and pass that gene on to somebody else, to their children.
Oh, okay. Okay.
So
Wow.
if you were to look at a map of the world and you see where there's malaria, those are the same areas that have large amounts of sickle cell.
And that's why it's more prevalent in those cultures then.
Right. It's not something unique to the people, it's unique to their environment.
Oh, okay. So it makes you wonder though, if you can change the environment, then somehow, which would lend to preventative measures. But I know before on the other show, you said there really are no preventative measures that
Yes.
you take.
So because I had a discussion with someone the other day, even if you got rid of malaria, that's not going to get rid of sickle cell. Because like I say, sickle cell itself it's a mutation. It's just spontaneously something bad. It's bad luck. And so whether you had malaria or not, there would still be people who would have this mutation.
Right, right. So, with all that being said, then what in your current research, I know you have a new website now, you have done more research. What have been your findings since we spoke last in terms of your research? Any new developments around?
Well, one of the there's a lot going on. I hope I can keep it all straight and remember it. What you're referring to my research, most of this has been very informal research.
Okay.
I use the whole world as my laboratory.
Okay.
I literally walk up to people on the street and start talking to them about sickle cell. And this is how I've learned what works, what's not working, talking to people who have it, who don't have it, who won't admit they have it, whatever. But actually, though, I have reached out and made contact with Case Western's research department, because I do have several ideas that I want to investigate. So one is, it dawns on me doing my curbside research, is that a lot of people who are at risk for sickle cell are not aware of their trait status. They don't know if they have the trait or not.
Okay.
So to me, you can't make any progress with sickle cell in terms of decreasing cases if people do not know their trait. Because if you don't know your trait, you cannot prevent sickle cell. And there are mainly two ways that I discuss the way to prevent it. And initially what I was talking about was preventing with science, meaning you go to an infertility doctor, you undergo what they call in vitro fertilization, make an embryo, then you test it and put a healthy one in the uterus.
Okay.
So that's one way to prevent sickle cell.
Okay.
The other way, I call it just say no. So that would be when you know you have a trait. If you meet somebody else with a trait, then you say, no, we're not going to have children together.
Right.
That method has been basically what has been available to most people. However, it doesn't work very well.
Well, if they don't know they have it, first of all, you gotta.
One, if they don't know they have it, but even when they know they have it,
Okay.
love is love.
Yeah.
And people will go ahead and take their chances and say, well, you know, we only have a 25% chance if we each have the trait, and whatever. And then
Is that a real statistic though?
the 25%?
Yes.
Yes, that's based in science. So what happens is, to get the disease, each parent has to have the trait. So if both parents have the parents each have two genes for their hemoglobin. One might be a normal and one might be sickle. So they each have 2 genes.
Okay.
So to have a baby, they get one from each parent.
Oh, I see.
So they could either get the 2 normals and be normal. They can get the normal from one and the trait from the other parent, and then they would just have the trait.
Oh.
But if they're unlucky enough to get the trait from both parents, then they'll have the disease. So there's 25% chance of sickle cell disease, 25% of not having the trait or the disease, and 50% chance that you will just have the trait.
Got it. Okay. That was a really great way to describe the that particular statistic. All right.
So the problem is
Mhm.
people think, well, 25% chance, I'll take my chances. Well, I always say I would not get on a plane that had a 25% chance of crashing, because that's pretty high.
Amen. That's a good way. That's a good
How-
point.
However, that number is per pregnancy, meaning just because your first one child has sickle cell and you have 4 kids, all 4 of them could end up with sickle cell.
Oh,
If they're unlucky enough to get the trait from both parents,
right.
they can still. So you could have 100% of your kids having the disease, even though for that pregnancy, there was only a 25% chance that they would have the disease.
Okay. Wow.
So I had a family friend who had 11 children. 8 of them had sickle cell disease.
What?
Mhm.
Did they know they each, I mean, they obviously didn't know anything about these statistics or the testing. They didn't.
Unfortunately, I don't know. And that's why I like talking to people,
Yeah.
because I like to know what they knew, what the doctors told them, what was their thinking, how did they make these decisions? Because to me, that's all a part of trying to figure out why we still are not making progress with decreasing the number of patients born each year with sickle cell.
Okay. So what are the current statistics of people born in the United States, at least,
Okay, so in the United
having the
States,
trait and or also developing the disease or
okay,
having the disease?
so in the United States, starting in the 1990s, they start testing every newborn in
Really?
every state for sickle cell disease and 30 other diseases, roughly 30 to 40. But there's no national, to my knowledge, database to tell us the exact numbers total or of the disease or the testing results. So it's state by state.
I see. Okay.
But the number that people use, which I'm suspicious of, is that in the United States, there are 100,000 people with the disease.
Okay. And that is a true statistic.
Well, this is what, if you Google, this is what will come up every time as if it's fact.
Okay.
However, 100,000 is such a perfect number that makes me suspicious.
I see.
I mean, how come it's not 100,010, for example?
Right. Uh-huh.
So that's the number they quote. Now, in terms of who has the trait, it's most common in African Americans, but white people, Hispanic, other people can have the trait.
Right.
And the statistics say between 8 to 10% of African Americans have the trait.
Okay.
Not like 10% because it's easier to do the math when you believe that.
Right.
But sometimes it says 8%.
Okay. So now, so you told us about your curbside research. You've given us a good definition of what sickle cell is. We talked about the statistics. So what is new or different in terms of treatment?
Okay. For some time, as far as treatment, there's a medication called hydroxyurea that has had some success in treating patients with sickle cell.
So it's treating the blood cells itself to lessen the sickle shape or to improve the shape of the cell. It's not treating the organs.
I actually don't know how hydroxyurea works.
Oh, okay.
It's an expensive drug. Medicaid, Medicare will pay for it.
Oh, will, okay.
Yes. Medicaid, Medicare will pay for treatment of sickle cell.
Oh, okay.
The other process that is utilized to treat sickle cell patients also suffer from anemia and the complications of anemia. So these sickle cells do not live as long as normal blood cells. So you're always being depleted of a normal amount of red blood cells.
I see, okay.
And they get sequestered or destroyed by the spleen or whatever. So there's a lack of these cells in patients with sickle cell. And then you have all the complications of anemia, fatigue, heart strain, et cetera, et cetera.
Okay.
So one of the mainstays is to give people blood transfusions.
Okay.
So a lot of sickle cell patients have over their lifetime, have a lot of blood transfusions. And so I work with American Cancer Society to encourage people to donate blood for this purpose.
Okay.
There's, everybody has different blood types, but some blood types are more common in certain racial groups than others. So the push is to get more African Americans to donate blood.
Okay.
So then Pfizer developed another drug a few years ago that was approved by the FDA, but then they found out that more people were dying from the drug.
Oh my God. I was just about to ask, what are there some side effects?
Oh, there are always side effects. So this one got pulled off the market.
Wow.
But the people in the sickle cell community were devastated.
Wow.
Because they thought, finally, we have a drug that'll decrease our crises, our pain, or they call vaso-occlusive, meaning vessels that are not able to provide oxygen, their organs. So they thought, this was going to be a really helpful drug. And unfortunately, it was not.
Wow. Okay.
So that's one thing that's going on. Then there are the cures that have been getting a lot of publicity recently.
Yeah, yeah.
One of the cures is called a bone marrow transplant. Now, that is not new. That has been around for decades.
Okay.
When I was an intern, I had a patient who had had a bone marrow transplant for cancer.
Okay.
Horrible procedure and very expensive. It costs probably close to $1 million also.
Oh my God. So who can who gets
Medicaid and Medicare pays for that.
Wow. Okay.
So there are a couple.
Is that considered elective, or is this in the case of someone's life is truly in danger and they have to have a bone marrow
I
transplant?
guess you could say it's elective in the sense that patients have to decide that they are willing to do this.
To go through it. Because it says dangerous.
It's a horrible process. You spend a lot of time in the hospital. There are risks. One of the complications is that they make you sterile. It makes you sterile or infertile.
Oh, okay.
So, so that, like I said, it's been around for a while. The other problem with that is that the best donor. So when you get this bone marrow transplant, what they want is a healthy person related to you to give you some of their blood cells.
I see.
To replace your sickle cells. So the best match, you have to be matched. Like a blood donor, when you donate blood, you want to give it to people who are most like you. Your blood's most like yours. So same thing with a bone marrow transplant. So the best donor would be a full-blooded sibling.
Oh, okay.
However, I found in my curbside research that a lot of people, when they have their first child with sickle cell disease, it is such a horrendous disease, and the impact on the family is so devastating that a lot of these people choose not to have any more children.
Okay.
Especially they chose it because at the time, many of them were not aware that they could still have a healthy child if they went through the infertility process.
So you can have, okay, so your healthy children, they could still have the trait though, is what you're saying.
Correct. Yeah. And that's something I'm not 100% sure about, is if you had the trait, would you be acceptable as a donor?
Right. Okay.
Now, there was, when it comes to like blood donations, the American Red Cross of Minnesota approached my older daughter and said, we want to see if you have sickle cell trait Because we're doing an experiment, we want to find out if a person with the trait is a closer match to a person with the disease.
Well, now, did this place that contacted your daughter, did they know you were doing research on
And no, it was just a coincidence.
Wow.
It was just a coincidence, but they were thinking that maybe, you know, because when you donate blood, if you donate anything, by a heart, kidney, liver, whatever,
Yeah,
it may be rejected
correct.
by
Yeah.
the person. So the more it matches that person,
Mm-hmm.
the less likely you are to
Accessible.
reject it.
Okay. Okay.
So I will have to look up I'll have to look that up about the bone marrow transplant
Mm-hmm.
to see if it can be successful with someone with the trait or not.
Okay. Okay. And then maybe
Ideally,
this
I would think,
time, maybe
I'm
next
sorry?
time, I said, well, maybe we can get together again, and then my niece will more likely be able to be on with us.
That would be nice. And I'm making a list of all the things I don't know.
Okay.
It's getting longer and longer.
Okay.
But hopefully I can find answers for the next session.
Okay. Wonderful. Okay, so it sounds like to me is sickle cell like a cancer though, because it's a mutation. Isn't that what cancers are, mutations that just kind of does, whatever, and is
So yes, most people who take care of sickle cell patients, their specialty is hematology oncology.
I see. Okay.
So there's a lot of overlap in terms of like for the next, there's another way to treat which uses chemotherapy.
Okay.
So the second way to cure, it's not a treatment, I'm sorry, to cure. Okay, so first you have the bone marrow transplantation. Second cure that was publicized starting last year, because there have been several children who've been cured in Cleveland, Baltimore, New York.
Okay.
And this process is also expensive. It costs $1 to $2 or $3 million per person.
But Medicaid and Medicare pay for it.
They pay for it.
Okay.
It also makes you sterile.
Okay.
You will see a trend when I'm telling you about these things is that Medicaid, Medicare pays for things that make you sterile.
Okay.
So the main drug that is used, the mainstay, hydroxyurea, can also make you sterile.
Okay. So that was are we on, that was one of the cures also, right?
Hydroxyurea is one of the treatments. That was the treatment.
Okay, treatment. Got you.
So the second cure, like I said, called gene editing, you undergo, I think you have to go through chemotherapy, presumably to kill off some of the sickle cells. And then they can, edit your gene or give you stem cells, disease, stem cells that are not diseased, to help you be cured of your disease. Okay. So the cure means you're going to have less times when you might have decreased blood flow to your organs. So you're less likely to have a stroke or pain or a lot of the complications of sickle cell.
But you'll be sterile.
Right. And if you've already had a significant complication like a stroke, it's not going to make that go away. Okay,
now we're talking about, and even in children, children can have strokes with sickle cell?
Yes, if you see a Black child walking down the street and they've had a stroke, that's usually because of sickle cell.
Oh, okay.
It's a horrible disease. It's an absolutely horrible disease.
Okay. So are the signs in the signs of stroke in children the same as in adults? Or?
Well, I would suspect so.
Okay.
I would suspect so.
Okay.
They talk about slurred speech,
right,
or paralysis and all those things. Right. But the other thing that happens too is it impairs their brain function. And so they can have problems in school when they've had strokes. They may have to undergo rehabilitation like an older person would have to. Now, I don't know specifically with sickle cell, but generally children's blood cells are more able to compensate for problems.
Oh, okay.
So if an adult has a stroke, the brain part of the brain dies, that's done, it's over with. But sometimes with some processes, children's cells, since they're still developing, have a possibility of more recovery perhaps than an adult would have.
Okay. Now, I know you're a radiologist, you're not a neurologist, but this is just kind of a side question that I've had for a long time. I was at a workshop one day and I don't know who the speaker was, but they were saying that a child's brain or the prefrontal cortex, which is the executive branch of the brain, correct? Does
Yeah,
not
they say the frontal cortex where you make good decisions.
Yeah, they call the executive branch. They say it does not fully develop in a person until they're like 26.
Yes, that's what I've heard, the same thing, 25 or so. So
Yeah.
children do a lot of stupid things.
Yeah. Yeah, but
But
I'm
some
like,
adults do
wow,
too.
you can't. I mean, some of the things that have been happening, and I wonder, if a person's brain is not even fully developed until that age, why are they, doing certain things? But I digress. That's a whole nother topic. Okay, so you said there was another third cure that
So there are two different types of gene editing. There's the bone marrow
repeat.
transplant, and then there are two different gene editings.
Okay.
CRISPR is the one that has gotten a lot of publicity. And so when you're born with sickle cell, you have what they call, when you're born, anybody, you have what they call fetal hemoglobin.
Okay.
So that's the blood that can help oxygenate you normally.
Okay.
But as you get older, the fetal hemoglobin starts to regress, and then your adult hemoglobin starts to take over.
Okay.
So if you have normal adult hemoglobin, life will go on as planned and fine.
Okay.
However, if you have sickle cell, as the fetal hemoglobin regresses, you'll start getting more sickle cell hemoglobin. That's when the problems start.
Okay.
So CRISPR, as I understand it, tends to try and prolong the fetal hemoglobin that the person has.
Oh, this particular
That cure,
oh,
CRISPR.
say that again. How do you spell it?
CRISPR?
CRISPR?
Yeah, CRISPR, CRISPR. I guess it's a trade
like
name. It's a trade name for gene editing.
Oh, okay, gotcha. Okay. Oh, that's interesting. So
So the other one, lentoglobin, which is also a gene editing process, as I understand it, and I don't understand much of it, to be honest, they edit your genes so that it's a more normal hemoglobin,
Okay.
not the sickle hemoglobin.
Okay. But the good news is currently, well, I guess I don't know if it's by state, but you said Medicaid and Medicare will pay for these.
Any place you live in America, Medicaid, Medicare will pay the $1 to $3 million for the gene editing cure.
Wow. But the bad news is, you have to give up having children.
Okay, so what you can do, and what I think sometimes gets included in that extra $1 million is they can save your eggs and your sperm.
Oh.
But that process can be complicated, and it costs money because you save them for 20, 30 years, depending on when the person decides to have children.
I see.
So that's one of the things that has happened is that because I have a friend who had the bone marrow transplant some years ago, and she did not have the option of something of the Medicaid, Medicare paying to save her fertility. So she's infertile. Now, cancer patients, they have a fund or whatever for them to preserve their fertility.
Okay.
But they have not yet, to my knowledge, developed an equivalent fund for sickle cell patients.
Okay.
And like I say, but now it seems that at least perhaps Medicaid, Medicare will pay to save your fertility, perhaps. Now, the boy, one of the first young men who had the procedure in Baltimore, his parents' private insurance paid. Wow. And they paid $3 million for him to get the cure.
Wow.
And since it was $3 million, I'm suspected that they also preserved his fertility.
Okay. Okay. Okay, that's interesting too. So you can preserve the egg and the sperm, and I guess I'm not sure how would you have to have
A freezer.
a freezer, but you could still implant it into, it can still be, the person that preserved their own egg can still have it fertilized with the sperm and then implant it in their body
Exactly. So it's almost like,
without passing on the disease?
well, okay, so if you have okay, so the process for them to get pregnant is like the same process to prevent having a child with a disease. Egg, sperm, put together, embryo, test the embryo, and then put the healthy one there. So if you have the disease, going back to these two genes that men and women have, if you have the disease, both your genes are sickle cell.
Okay.
If your spouse is normal, both of their genes are normal.
Okay.
So if you use your genes, whether it's male's sperm or female eggs, then the baby would have the trait.
Okay. But
Because the only thing that the person with the disease can donate to this process is a gene that has the trait.
I see. Okay.
But they wouldn't have the disease.
But their partner needs to not have the disease.
Ideally, the partner should not have any trait. However, if they had the trait, they also have a normal gene.
Okay.
So if you fertilize the trait with the normal gene, and you can know that that happened because you can do that pre-implantation genetic testing. You can test the embryo and see, does it have the trait or does it have a disease?
Okay.
And so many people, I suspect, would elect to have a child with just a trait.
Okay. Right. Okay. Sounds very interesting. That was still a little bit confusing to me, but I will have to handle that for now.
It's confusing to me. I have listened to lectures on gene editing, and I'm sitting there thinking, how can any parent give what we call informed consent? Because informed consent means you understand. And I don't think very many people would ever completely understand. In fact, the boy in Baltimore, after the procedure was over and successful, they were like, we didn't even know what they act like they didn't even hardly know what they were getting into.
Wow. Okay.
So that's
We'll
why
leave that for the scientists, the people that the people that do that.
but that's why I say to prevent it, parents can understand. You take an egg and a sperm, you put them together, make an embryo, test it, put the healthy ones in the uterus.
Gotcha. Okay. Okay. That simplifies it.
So something else is going on. Okay, so since I last talked to you, I gave a lecture last week on sickle cell.
Okay.
It was very well received. I was very happy with how it turned out.
Okay.
After the lecture, I had a young man come and tell me, well, he had thalassemia trait, which is another blood disorder, a mutation that has a lot of similarities with sickle cell.
Okay.
So we talked about that. But the other thing we talked about, I meant to send you this card that I developed. Can you see this card?
It's kind of hard to see, but what I can
I'm going to send you.
Send it to me anyway.
I'll send it to you by text. I have it in my photos.
If you want, you can share. Why don't you go ahead and share the information?
I will go ahead.
Okay.
So when I did my curbside research,
okay,
I found that a lot of people, as I mentioned, did not know their trait status.
Okay.
And why that is still somewhat of a mystery and still something that I wanted to do formal research about. So one of the projects with Case Western was I wanted to find out who knew their trait status and ultimately find out what the barriers are to people knowing. Why don't people know?
Okay.
Because even of the ones who were less than 25 years of age, who should have been tested at birth, they don't have their records. They don't know what the results were. They don't know if they were tested. And so, so that's a problem.
Okay.
So what I developed was, because I said, even when the doctors tell the parents, okay, your kid was tested at birth and they have the trait for sickle cell, that information can sort of evaporate. Maybe the doctor tells them, maybe they forget. Or maybe the doctor tells them, but they only tell them one time. Or maybe they tell them, well, you have sickle cell, and that doesn't ring a bell with the parent. So I've met people on the curbside, some of them, who'll say, my daughter has something. And then on further discussion, it was thalassemia. Well, thalassemia is not a word that most people are familiar with. It's has a lot of letters. I don't even know how to spell it. I have to rely on spell check. So other parents will say, one of my child has a sickle cell trait, but I don't remember which one. So I developed this card, very low tech. And on the card, the pediatricians, I'm hoping, will give to their patients, and they are actually, it's already being used, where it has a patient's name, patient's birth date, so they know which child. And then it says, I have the trait for, and you can choose sickle cell, thalassemia, cystic fibrosis, Tay-Sachs, or other.
Okay.
So therefore, I'm hoping that by utilizing this, and I've sent them to physicians, pediatricians in Ohio and Michigan.
Okay.
Hopefully by using this, this will help families and people remember what they have.
Right.
So when it comes
They can
time,
they can have it on them in case of a medical emergency.
well, some people say you can put that on the phone. On your phone, they
Oh.
have medical alert.
Oh, okay.
And the trait is significant even by itself, to the extent that the head of adult sickle cell at university hospitals says that when a patient comes into the emergency room with just a trait, he gets a notification.
Okay. And how did you say, now how can people get access to these cards, or they make their own, or?
Well, I am, right now, I'm directly shipping them to pediatricians who are interested in using them.
Okay.
I'm having them made on Vistaprint website, and I just put in the names of pediatricians or hematologists who want these.
Got you. Okay.
I have a picture of it on my LinkedIn account. And so that's one way you could at least see it. Maybe, I don't know if you could print it out, download it that way. So that's what I'm doing with that. So I'm very happy and proud about that, because I think.
Yeah, and by the way, I'm sorry, you did send that to me.
Okay.
I did get that. Yeah.
Right.
And I
So,
think I did too.
and I know we're getting a little bit short on time.
Yeah.
So,
well, I want to make sure you give your website information too, and your contact information if you want to share.
Right. So my website is preventsicklecell.com, all one word.
Okay.
And if people want to reach out to me, my email address is hazel@greenyoung, all one word, .com.
Okay.
YOUNG, and green like the color.
Okay. I want to repeat that. The Prevent Sickle Cell, PREVENTSICKLECELL.com.
Correct.
Okay. And then your email, HAZEL@GREENYOUNG.com. Hazel@greenyoung.com. Okay. So is there anything else that we missed? And like I said, it looks like we are going to have to do another one, because you're looking up some information that to get back with us on, and you're still going to be doing your curbside research.
And also, hopefully, my research with Case Western will go forward too, which will be in the lab or wherever, not on the curb, but as much. So there were two things I'll try and say quickly. As a physician in the healthcare setting, I always suggest that patients have to be their own advocate. And I also feel like if you're going to be in a situation that's complicated medically, you need another person with you. Because two pair of ears, two pair of eyes are more effective.
Absolutely.
And what I say is, I, as a physician, even if I'm going to know I have a doctor's appointment, I make a list of all the things I want to talk to them about. So I suggest people, if they're going to go see a doctor, make a list. And if you don't have somebody with you and you're not sure what the doctor is saying, tell the doctor to write something down, write the word down, spell out thalassemia for you so you'll know what they're talking about.
Right. In other words, letting patients be their own advocates too, as well as having someone's support of their. So those are great suggestions. And I know a lot of people sometimes don't know what to ask the doctor, or might not feel that their questions are important. And knowing that no question is a stupid question, right?
Exactly.
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 Yeah, when it comes to your health. Yeah.
Right.
All right. Well, thank you so much for Dr. Hazel Green Young for being on again. And I'm definitely going to invite you back to share more information. And hopefully we'll be able to have my niece come on. And she, I think, would be a good representative, and did share that she might have some questions or even want to share her story as well. All right. So until next time, everyone stay safe, stay well. And namaste. All right.
Namaste. Thank you.
You're welcome. Thanks for being here.